Good morning, everybody, and welcome to the Global Surgery Grand Round. I have an apology from Sarah, who was meant to chair the session, but she has a family emergency. Sarah is part of our Global Surgery group and is doing a master's in public health together with her anesthetic input. And she has put all this morning together, and I'm just here standing in for her. So today's theme from our anesthetic colleagues is sustainable healthcare. We're very privileged to have two excellent speakers. First one is Søren, who's an anesthetic consultant, but very much representing the trust and working with the trust in green energy and green theatre. And his work extends into the university as well. And he's won several Trust Grade Awards for his input in sustainable healthcare for our trust. Following him, we have Sanyu May, our visiting speaker, also on sustainable healthcare. Sanyu May has put in a lot of work into the educational side of sustainable healthcare from an undergraduate level as well as a postgraduate level, and she holds very high positions in both those arenas. She's also a fellow of the College of Green Templeton, and we very much welcome you into Oxford for today. So I'll allow Søren to kick off.
Thank you very much. Thank you, Kahila. And thank you very much for the opportunity to come and speak at this surgical Grand Round, the Global Surgery Grand Round. As Kahila mentioned, I'm one of the anaesthetic consultants working here in Oxford. And I guess as the first part of this little talk, or this little half, is going to be about perioperative sustainability and what that encompasses. So the first thing would be sort of, how do we define it? Let's revisit the term, and it was defined quite nicely by Chantal Rizan, who I'll be referenced quite a few times because she's been an excellent driver in the evidence group around this. And she made this pyramid showing that at the top you have the low-carbon alternatives, things like maintenance, repair, recycling, reuse, low-carbon alternatives. And then onto that you have the lean service delivery. That would be reducing the amount of visits, for example, a patient does, trying to provide more patient throughput through a day, that kind of thing. Following on from that comes more nebulous terms, things like patient education and empowerment, and at the bottom, surgical disease prevention, which in many ways, if you think about it, if you want to drive net zero, having no surgical requirement in the first place is probably the way to do it. The shape of the pyramid is very important because it shows also where the bang for your buck is, if you like. The bigger the wedge, the bigger the impact you can have if you were to exert your influence in that space. I guess the next thing is to link it to global surgery and to just emphasize the fact that this is very much part of a global surgery talk, global health in general, because the focus will be on equitable provision. Climate crisis disproportionately affects marginalized, vulnerable populations, and we see that in these vicious cycles, and we'll go through them one by one. So firstly, you have the impact of the healthcare on climate. You have the increased need for healthcare, as you see, as you come down. Then you have an increase in greenhouse gas emissions due to the use of healthcare. And this is what we often talk about in the net zero pledges that we have. And that then, of course, leads on to a worsening climate crisis. On the flip side, on the other side, you have the impact on inequality onto climate. And that is, you have this ring of a rise in socioeconomic inequality due to vulnerable populations, which we know, looking at the Gini coefficients of nations, the wider the Gini coefficient, the wider the inequality within a nation, the bigger the greenhouse gas consumption will be in terms of the policies that they're putting through. All of this, again, feeds into a worsening climate and nature crisis. And finally, in the center, you have the impact on the disadvantaged groups, the marginalized communities. And I guess here you have a number of things that interplay between the two. You have greater climate vulnerability depending on potentially infrastructure-related reasons or housing-related reasons. This then leads on to poorer health due to climate change, which both drives an increased need for healthcare, but also drives towards a disproportionate loss of assets and income. So it all links, and sustainability is very much linked with a broader discipline of equity, and that's really important. So let's revisit this. Marco, who's a graduate entry medical student here in Oxford, he set about looking at sustainability articles published in all listed anaesthesia journals and said, okay, well, how many of these have a focus on each of these in terms of the primary outcome measures? And he found the pyramid was inverted. He found that the vast majority of the studies focused on low-carbon alternatives. There were some on lean care systems and some looking at patient empowerment, some on disease prevention. But the last two was very much more, not necessarily tokenistic, but not necessarily part of the true primary objective. And that was 199 articles in total, so it was quite a big group of articles. Looking at the ped surgical, Kavito's an ICU and education registrar, as well as Anna, who is a Dutch medical student visiting in Oxford. They reviewed articles that focused on climate and pediatric surgical provision, looking at how these things overlap in the literature. And the model you see here is the syndemic model of health, which is used to show the complex interconnection and interplay between the health conditions and populations. And again, the small boxes in green, it may be a little bit difficult to see, but they found that the articles that they identified, even though they actually looked proactively for the intersection between these two in terms of climate crisis and so forth, we're still looking at little pockets, looking at the effect of climate change on the surgical illness, looking at the effect of the surgical provision on climate change, and then a little bit looking at the mitigation. Again, it was more focused on the leaner alternatives. And we see this overall. So looking at PubMed, we have this exponential rise in articles available looking at life cycle assessments, which is, if you like, the gold standard of carbon footprinting anything, really, anything from procedures through to products and so forth. And if we look at the healthcare LCA, again, Chantal Rizan, who I mentioned earlier, has been a huge proponent in making this huge online database publicly available. And they cumulatively collect all the data there. And you see there's been a sharp rise in the availability of these healthcare LCAs. Now, importantly, the grey wedge, the dark grey wedge, that's surgery. Okay, so a huge driver of the data comes within this field. I like to think that anesthesia fits within that. We have a lot of data as well. We're certainly within the blue and also in the light grey. We have sort of no dedicated field within this, but it's fine. But there's a lot of data being made available. And I guess maybe just as a last one, looking at the current evidence, there was a recent review published, a scoping review, looking at the interplay between surgical disease burden, surgical care delivery, climate change, and how all these things link together. And they made this nice little sort of social media friendly infographic that sort of outlined how it all links together. And I guess the overarching focus, which is in the center there, is there'll be a rise in surgical demand over time, and we know this is well evidenced. Meanwhile, there'll be a reduction in availability of surgical delivery, purely through either infrastructure-related issues or lack of climate adaptation measures within the healthcare systems. And many of us will have encountered during the summer heat waves that has been in Oxford, theatres being shut down due to overheating. We know that's on the rise as well. Now, importantly, we have this little box down the corner, a little red box. And it's important that they include this. Within this, you can see at the bottom, it has equity. And they included this even though they actually didn't find any data. They said this is a data gap. In all the data that we reviewed, it's been mentioned as important, but not something that's actually been explored. So again, we have something that we know is linked to all this, and yet we haven't really explored it in the literature. Coming back to Marco's paper, he looked at, in all the articles, the 199 that talked about sustainability in the anaesthesia journals, he found that quite a few of them talked about inequality or inequity, and here this is sort of a word cloud of the words used in that discourse. But it was either used in the introduction to introduce the topic and why it's important to talk about sustainability and climate change. So it's more of a, not part of the study, but just as a, this is important because. Or it was talked about in the discussion as a limitation of generalizability. So actually the opportunities to talk about inequality, inequity, or even climate justice were not really grasped fully in the dedicated articles on sustainability. So this comes back to the title of the talk, the distraction of carbon dioxide equivalence. Why do we have this tunnel vision? This focus on carbon emissions as the sole sort of, if you like, exemplar of what sustainability represents, even though we know quite carefully and quite clearly delineated in the literature that there's much more to it. I'll come with a couple of suggestions of my own, and feel free to comment or question it. So I think one of them is this overarching narrative of healthcare accounting for 5%, 4 to 5%, depending on the literature of the global footprint. And it's really important, and we should not neglect it. And it's led to this huge drive towards reducing the carbon footprint, which again is important. And in 2020, I think it's important to always say this, NHS as the first public health system put forward this greener NHS report, the targets of being net zero by 2040 or the wider supply chain by 2045. Which was put into legislation a couple of years later. So, you know, in the UK, within the NHS, this is incredibly important, and that's very much part of our day-to-day work in terms of being part of that drive. Increasingly it will be. And I think you can sort of see the inflection point in terms of the available data around this. In 2020, all of a sudden, there's this steep increase in the available data around the life cycle assessments because it's really important, and it's a big part of the sort of the way that we can evidence-based reduce our carbon footprint. However, it does simplify the environmental impact. Yeah, so this is sort of an early, again, in the same years the NHS put out the pledge for greener NHS, for the net zero pledge. There was this really simple infographic that said, well, a single operation is the same as 2,000 plus miles in an average petrol car. And I think this is kind of the way that we've been starting to translate carbon footprints. How far can you drive in a petrol car? And again, it's useful. It's important to have some kind of comparator, but it's risky business because we start reducing things down. It's very reductive and it becomes sort of, okay, well, it's this much. And I guess we need to have some kind of useful measure, but I would argue that we might need to revisit this. A great paper, again, Chantal Rissan, looking at the PPE in the NHS. They did this great exercise and actually did a really thorough analysis of the carbon footprints of our PPE. And this was figure number 1. You can see the carbon footprint of each of them. You can see how much of it is waste, how much of it is production, this, that, and the other. Very useful. And it sort of makes for that immediate talking piece. Okay, well, this is the carbon footprint of X. If we use this many, we can reduce it down by this much in this, that, and the other. So it's a really useful thing. But you have to go into the supplement to figure number 10 to see that in actual fact, and I'll see if I can just reduce this down. In actual fact, the carbon footprint that's produced is only 1 out of 18 domains within the wider environmental carbon footprint. There's a huge part of it, a much more depth to the environmental impact that's really important and gives a much better understanding of the ecological impact fully. And often we have people saying, well, the problem with reusables is because of marine eutrophication or this and the other. And these are important talking points. These are things that we need to incorporate into the conversation, even if when it comes to reusable, it's maybe less of an issue in terms of the shift. Now, at this point in time, I'd like to invite you to join on Menti. It should work. If I can just see if I can get it back onto here. There we go. So I guess just to emphasize the point, I'd like to just spend 1 minute, or the people who've joined, of thinking what has the biggest footprint and what has the smallest. So if you go into Menti, I'm pretty sure the code should be correct. Yes, it's the right code. And then just spend a minute looking at what you think. Should have that countdown clock, like the dee-dee. Okay, so there's some votes coming through now. So I won't be able to show you necessarily on the screen the votes, but I'll just tell you the biggest and the smallest of what's coming through. And it's pretty good. There's quite a bit of agreement between the many people. Actually, thank you for all the people who voted. So the main one that's coming through is the reconstructive breast surgery being the biggest footprint. That's pretty broadly agreement. And then cataract surgery, UK, 5 hours of propofol. That's the one anaesthetic in there. Oh, no, hang on, there's also Entonox. And And then Entonox fourth, and then cataract surgery in France as the lowest. Now, this is the answer. So, recon breast surgery is the biggest footprint. TCI propofol is the lowest. And I guess in many ways, when you talk about anaesthetists talking about the carbon footprint, this is often what we come down to talking about, vapors or TCI propofol. Like that's the one thing that we often can sort of align with. That's a big talking point. But you can see Entonox has a huge footprint of its own, and that's just, an hour's worth of it. The cataract surgery in France and the cataract surgery in UK, there's it's half the footprint. And this is where it starts being useful, because you can compare, okay, well, how come France is much lower than the UK? What's the sense of that? And it's the throughput. They have much higher patient numbers coming through, so the energy usage of the theatre suite is shared across a much greater number of patients. And with that, you have, a good throughput theatre, but you also have a lower footprint per patient. And that's where it starts being useful, yeah? And I guess the next thing would be, what other things can we compare it against? So I would invite you to start having other comparators than petrol cars. These are a few suggestions. And Hilary here in the audience gave me the How Bad Are Bananas by Berners-Lee, and that is a phenomenal read, and it sort of gives a good overview of these things. So I've included a few, but there's many. So a kilo of rice is about the same as 5 hours of TCI propofol. And I think this is where we start seeing the issue with carbon footprinting, because it's not the same. You can't say you can either have a kilo of rice or the anaesthetic for your procedure. It doesn't make sense. And we're starting to compare things that don't really compare, because they are very different things, even though they have the same currency in comparator. Leg of lamb, Christmas success in the UK, that's an interesting one, the UK average. If you're interested, a lot of that is down to travel and food waste. And I guess if we were to keep adding to this list of things that we can compare against, just because, now we have to scale up, why not? Looking at Oxfordshire carbon footprints. So I'll just remove the little box here. So the lowest fifth earners across a year have a footprint of about 5 tons, while the highest fifth of earners in the Oxfordshire has 20 tons. That's a huge difference, a really big difference between. And, the overall footprint for Oxfordshire, if you take it as an average, is 6 times above the global average, which is 1.36 tons, if we were to meet that 1.5 degree target, which is about half of the world population fits that particular carbon footprint. So it's useful to have carbon footprints, okay? And I think that's really important to emphasize. But we shouldn't necessarily reduce down all sustainability to a carbon footprint, because there's much more to it. And I think it's easier to compare, okay, what's more a cataract in UK, 5 hours propofol. You can compare like for like in a way when you have the same currency. But I'd like you to consider that there's more to it. And again, if I can it's the same Menti, so I should automatically, if you still have it open, bring up the next question. Because these are also decisions that we need to take, really, if we have the data. And the data is available if you look for it for many, not necessarily all. But what would you prioritize? What would you say, well, that's less important than the other? And it starts becoming much more mucky. The social impacts are not as straightforward, as they're all really important. But of course, everyone will have sort of their own focus, their own interest in this. And we have the data. Loads of reports are published around this. We know that through the good work of the BMA and predominantly Prof Butter, there's a lot of issues, especially in the supply chains around perioperative care, when you go right down in procurement all the way back. And not often we have all that data available necessarily because of the many ways it changes hands along the way. And we know that funding from a good report in the BMJ recently, looking at the links to oil companies and so on. So, these are important things to consider. These are important things to incorporate in our decision making, but very rarely are these considered part of sustainability. And I guess that's the problem. We start simplifying the big vicious cycle into simply greenhouse gas emissions due to use of healthcare. It's important to broaden that back out again and get the whole cycle in, so that we appreciate all the different aspects when we're doing sustainability in healthcare. Even if it's easy to look at the carbon footprint, we should take the much broader implications into the consideration as well. And I guess to use an analogy, it's always good to have an iceberg. This is kind of what we're dealing with. We're looking at the carbon footprint at the top, but I would argue that it's probably more like that, because the carbon footprint is such a small part of the much bigger issue of all the social and ecological impacts that are much broader. So I'll finish with a little quote from, and I've lifted it out from a conclusion of a recent review by Sophia Chen et al., just recently published in January. So global surgery and climate change are two matters of social justice, and I think that's key, whose solutions must synergistically centralize the health of both the planet and its most vulnerable people. And of course, here they say global surgery, but this applies everywhere, here as well. So yeah. So I'll leave it at that. Thank you very much.